I'd like to welcome our witnesses for the second panel, beginning with Dr. Sonu Gang, Chief of the Sunnybrook Health Sciences Center, Department of Psychiatry, followed by Dr. Eleanor Gittins from the Canadian Psychological Association. Dr. Sam Mikhail, psychologist, is also present via video conference. Thank you all for joining us. We're going to begin. Each will have 5 minutes, and we'll begin with Dr. Gain. The floor is yours.
Thank you very much. My name is Sonu Gand. I'm a full professor, psychiatrist, and governor at University of Toronto, chief of psychiatry at Sunnybrook, and a past president of the Canadian and Ontario Psychiatric Associations. My expertise is psycho-oncology, working with cancer patients and their families. I am not a conscientious objector and was physician chair of my prior hospital's MAID team. My roles inform my expertise, but I'm presenting as an individual, not for any group. Thank you for the chance to speak. My testimony is not easy to say, nor easy to hear, but it's necessary to be said. Those seeking expansion claim not providing MAID for sole mental illness is discrimination, echoing claims by Senator Couture. The opposite is true for 3 reasons. MAID is for irremediable medical conditions, ones that we can predict won't improve. Worldwide evidence shows we cannot predict irremediability in cases of mental illness, meaning the primary safeguard underpinning MAID is already bypassed, with evidence showing such predictions are wrong over half the time. Scientific evidence shows we cannot distinguish suicidality caused by mental illness from motivations leading to psychiatric MAID requests, with overlapping characteristics suggesting there may be no distinction to make. Finally, those with mental illness have higher rates of psychosocial suffering. This all means MAID assessors will be wrong over half the time when predicting irremediability, will wrongly believe they are filtering out suicidality, and will instead provide death to marginalized suicidal Canadians who could have improved. That is the ultimate discrimination. Those setting policy have reassured us we're ready to provide MAID for mental illness. I've reviewed our legislation, the Health Canada Practice Standard, and the CAMAP training for MAID for mental illness. As someone who supports MAID in general, I assure you we are not ready. Regarding irremediability, Dr. Gupta acknowledged in her 2020 AMPQ report that it's possible a person who has recourse to MAID could have regained the desire to live, saying this should be an ethical decision each time. Her 2022 expert panel refused to recommend any additional legislative safeguards, despite Canada lacking legislated requirements for due care and no reasonable alternatives before MAID, unlike other countries. Professor Downey claimed irremediability is a legal term rather than a clinical concept. Try those mental gymnastics on your constituents. Convince them it was okay their loved ones with mental illness got MAID, not because of a clinical assessment based in medicine or science, but on the ethics of the particular assessor. Regarding suicidality, Senator Couture and Dr. Green claim suicidal people won't get psychiatric euthanasia, and Dr. Gupta claims assessors can identify and separate suicidality in MAID requests because they have been doing it.
Madame la Présidente.
Madam Chairperson, if I may interrupt, could the witness please slow down a tad? He'll have the opportunity to say everything he wants to say, but when it comes to simultaneous interpretation, he's a bit quick. His remarks need to be intelligible, after all.
I'm not losing time.
You've paused the time, so you can continue and slow down your speech. Thank you.
Well, I can't slow down or I won't be able to finish my comments. So.
It's because of the translation.
Well, I'm sorry. I've got prepared material I'd like to finish.
Okay, so we're at 2:54, and I stopped as soon as there was an intervention.
Okay, thank you.
Okay, thank you.
So saying something false repeatedly doesn't make it true, and evidence shows they can't make the distinctions they claim. The CAMAP curriculum dangerously teaches assessors not how to distinguish suicidality from psychiatric MAID requests, but convinces them that they can, leading to remarkable statements like Dr. Gubitz saying, quote, is the patient suicidal or do they actually have a reason to wish to die, which is not the same thing. This highlights a key problem with psychiatric MAID assessments, namely the hubris of the assessor thinking they can determine irremediability and distinguish suicidality from psychiatric MAID requests when evidence shows they can do neither. Remarkably, the CAMAP suicide module neglects mentioning known risks to marginalized populations. European data show a gender gap of twice as many women as men getting psychiatric euthanasia and of unresolved social suffering. Dr. Gupta stunningly dismissed this, saying this gender gap, quote, doesn't concern her since nobody really knows what it means. Signals of a gender gap are already emerging in Canada on track 2. An echo chamber has driven expansion with reassurances but no safeguards. It's reassurance theater. In recent weeks, I've worked with over 200 colleagues debunking a slew of disinformation shaping our policies. You can see today's piece in impactethics.ca and check the new Society of Canadian Psychiatry site, sockpsych.org, for other links. CPA Chair Dr. Freeland reluctantly acknowledged she couldn't say all the readiness is there, and the lead for CAMAP's curriculum, Dr. Lee, wrote she has grave concerns about our preparedness. Dr. Gupta testified 1 to 2 patients in her practice would qualify. I can't speak to the severity of illness she sees, but Scott Kim, a researcher at NIH, estimated we'd have well over 2,000 patients yearly getting psychiatric euthanasia. This expansion is not so much a slippery slope as a runaway train. Like the Lac Mégantic disaster, government has plenty of signs we should not be